the lymph node has some lymph node metastasis is in this stage. And then we just say the last stage, the fourth stage, any disease that any carcinoma, breast carcinoma that metastasis to the distant organ. For example, liver, bone, lung, brain. This will be stage 4, and except 1, 2, 4, there's stage 3. For our breast cancer patient, the diagnostic routine, we can see the diagnostic routine. Just now I have instructed. The first one is to do the physical examination, and then to do the ultrasonography and mammography. And it should be next to the biopsy. And after the biopsy, we should do the MRI and to make a treatment plan. This is another ultrasonograph pictures. You can see the specular boundary of this lesion. And there I will introduce you the classification sign of the breast cancer in the mammography. Just now I have shown you the specular-like mass in the mammography. This is category 5. And then I will introduce another sign. This named calcification, not coarse calcification. It is microcalcification. Microcalcification, which was grouped or just distribute around the segment. It strongly reflects. Maybe it is a carcinoma or DCIS or intraductal carcinoma. In the MRI, we can see the mass in the upchondrate of the breast, and then we do the enhanced pictures. We can have an enhanced curve. The construct is quickly absorbed by the breast and then sustain plate. Decline so slowly. It was a characteristic of the malignant lesions. If it is fibroadenoma, maybe the curve will be just like this. Okay, the last part is the treatment of the breast cancer. At first, we should emphasize that the breast cancer is, from the beginning, is a systemic disease. Not just the lump, just the mass. It's a systemic disease. It can have the blood metastasis in very early stage. So we should give her a comprehensive therapy, the therapy including the local therapy and the systemic therapy. There, I have shown you the most useful method in the treatment. The pure one is the regional treatment. The first is surgery, and another is radiotherapy. And decided the systemic treatment, including the chemotherapy, endocrine therapy, and target therapy. The target therapy is developed just around this years, but it's so useful.
What exactly mean?
The normal clonal antibody therapy. Okay, first we discuss the surgical treatment. The first method of the surgical is the radical mastectomy. The radical mastectomy is invented by Hasted, so we call it Hasted operation. And in this operation, we will remove the nipple alveolar complex. The skin just at the surface of the lamp, and then the whole breast and the fat tissue and lymph node in the axillary area, and also including the muscles, pectoralis major muscles, and the pectoralis minor muscles. So it's the radical mastectomy, and then the extensive radical mastectomy, compared to the radical mastectomy, it also including the internal lymph node. And this method we not use. These two kind of method now is not used in clinical. And the third method now is prevalent in the China, because the breast conserve operation is not so popular. So mainly we use the third kind of operation. It named modified radical mastectomy. There's two kinds. The first one is ultra-close, and the next is patty operation. So what's the difference between 1 and 3? For the first kind of the operation, we should remove all the pectoralis major muscle and the pectoralis minor muscle. But for the 3 kind of modified operation, we needed to move the muscle. And for the first, this is ultra-close type. Keep these 2 muscles, and patty, we just move the minor muscle. And for some patients, especially the BCIS, we can do just the simple mastectomy is enough, BCIS. And the 5th method, breast conserving surgery. In Europe or American, maybe there 50 or 60, or sometimes can be 70% patients use this method to preserve their breast, because they are more concentrated on the cosmetic result of the operation. And of course, there's some large choice to compare the breast conserving surgery and the radical mastectomy, to compare the result. And we have the result that the prognosis is same. But the recurrence later is slightly high in the breast conserving surgery, slightly high just. So how can we do the breast conserving surgery? We just do the lumpectomy, move the lump, to move the mass, and then we can do the axial staging. So why I write here just axial staging, not axial lymph node dissection, because we have a very special kind method to check if the lymph node is metastatic. We call it sentinel lymph node biopsy. So if the sentinel lymph node, have you heard this? Yeah, it means the first lymph node or first station of lymph node that the tumor is drainage. So if we can also call them guard. If the guard is suffered, maybe whole of the army is suffered. But if the guard is clear, not suffered, whole of the army is not suffered. So we can check the sentinel lymph node. If the sentinel lymph node is negative, we needed to do the axial lymph node dissection. And if the sentinel lymph node is positive, we should do this. And then for breast conserving surgery, we should also do the radiotherapy to the whole breast to avoid the recurrence of the lesion. Okay. 1, 2, 3, 4, 5 is the destruction operation, and then we should do some good things. So we can also do the breast construction. But here we will not inject it. Okay, this is the picture of the radical surgery and breast conservation surgery. It obviously, if I was suffered from the breast carcinoma, I will choose that kind of operation. And we will talk about the eligibility for the breast conservation. Tumor, we used to use 3 centimeter to limit. If it is less than 3 centimeter, we can do the breast conservation surgery. But now, even the people have a 5 centimeter breast mass, if she wants to preserve her breast and after operation, you will have a cosmetic result is very good. It's okay. And the very important thing is you should move all the malignant lesions and have a negative boundary, have a malignant age. And for the patient age, because the more younger, maybe the more malignancy for the breast cancer patient. So for the patient below less than 35 years old, maybe breast conservation operation is not so suitable for her. But if her want to select this kind of operation is also okay. Why the more younger is more easy to because more younger is more easy to recurrence. Okay, and let us see the sentinel lymph node is the first drainage lymph node of a certain area. It can be 1 lymph node or 2 lymph node or sometimes 3 to 4 lymph node. Yeah, but it's the first station. And use the contrast and the CT scan technique. We can show us the sentinel lymph node, the drainage, and where the sentinel lymph node is. Usually it will be in the axillary area and just at the outside of pectoralis muscle, major muscle. use the sentinel lymph node biopsy, we can have less invasive to the patient. And how do we find it? We can use blue dye or radioactive tracer. This shows, you can see, finally I find the sentinel lymph node, and the lymph node is blue because I have used the blue dye. And before I open the incision, I cannot know where is the blue dye. So this time I should use the probe. And which one to direct the probe? You can see the first picture, we have injected some radioactive tracer into the nipple areola area or just around the mass. And then after 2 or 8 hours, this tracer will deposit at the sentinel lymph node. So if you use the probe, it has a hot spot. The probe will have a hot spot, and then you can find where the sentinel lymph node is. With a very small incision, you find the sentinel lymph node and then send it to the pathologist, and then to decide if we should do the axillary lymph node dissection. Just now we talk about the surgery, and then another regional therapy is radiotherapy. The radiotherapy are including two methods. The first is whole breast irradiation. Two methods. The first is for the breast conserving surgery, and another is for the post-mastectomy radiotherapy. And in the breast conserving surgery, we can use two kind of method. The first, I show the picture is just in the operation. After operation and do the radiotherapy, you use this belt, this beach belt. It is partial breast irradiation. And of course, we can also to do the whole breast irradiation after the operation, after the chemotherapy. And if for the patient, which patient should do the chemotherapy? Of course, the breast conservation patient is one group, and another group is for those patients have large size mass, especially larger than 5 centimeters. And for those patients have some lymph metastasis in the axillary areas. If the positive node is larger than 4, the number of positive nodes is larger than 4, you should do the radiotherapy. But if the positive node 1, 2, 3, we just suggest her to do. And the systemic therapy, the first is chemotherapy. Chemotherapy is more popular in the breast cancer therapy. For those patients, we should use this method. The first group is have a metastatic lymph node, and the next group is the node is negative, but she has some high risk factors. I think because we just have 3 classes to explain this to you. So which is the high risk factor? Maybe you should look at your books. For example, less than 35 years old, HER2 gene positive or estrogen negative. They are also the high risk factors. And which kind of drugs are usually used in the chemotherapy of breast cancer? We can see two kinds of drugs. One is anthracycline. This group of drugs is used popular in our therapy. And nowadays, taxane-based chemotherapy is more and more popular, and we found it's more effective than the anthracycline-based chemotherapy. And for the details of the regimen, I will not instruct it. And third, we should know our term, neoadjuvant chemotherapy. I have mentioned that before. Yeah, it means if a patient was diagnosed breast carcinoma, and we not from the first step to give her the operation, we choose chemotherapy. Yeah, we just first we do the chemotherapy, and the mass is still here, and then from the chemotherapy we can have some information. The first is if the drug is sensitive. If the drug is sensitive, the mass will become smaller and smaller. And then the second function is if I can smaller the mass, so I have more opportunity to conserving the breast. So sometimes we can change our surgery plan from the radical movement to the breast conserving surgery. Yeah. And the third function is because this disease is earlier bloody metastasis. So the more important is control the carcinoma cells in the blood circulation. Next, the systemic therapy is endocrine therapy. This is very important. Why? Because chemotherapy is not easy to serve. Yeah, some patients will quit after 2 or 3 cycles of chemotherapy. But endocrine therapy, if you can do this, you can easy to take. And we will separate patients in several groups. The first group is high responsive group. For this group patient, usually estrogen is positive and progesterone is positive. And if you give her the drugs, for example, tamoxifen or aromatase inhibitor, maybe it has a higher effect. And some patient is in the group of incomplete response group. For example, has a lower percent of estrogen positive. They report as estrogen is positive, but it's 5 to 10% cells are positive. And maybe the progesterone is negative. So for such kind of patient, we don't know if the endocrine therapy is useful for her, but we can try this kind of therapy. But for the patient with estrogen negative and progesterone negative, this patient is not suitable for the endocrine therapy. And 2 kinds of drugs are used in endocrine therapy. The first is tamoxifen. It's a good standard. Maybe from the 1970s to the 1990s, it's the good standard, and so useful for the either pre-menopause patient or post-menopause patient. But now For the post-menopause patient, aromatase inhibitor is become the first degree. And there are three kind of drugs: anastrozole, letrozole, and oxymethylmethane is available. While we use the endocrine therapy, we know the estrogen is produced in two ways. The first way is from our ovary, produce the estrogen, and another way is to the adrenal gland to the patient. And for the pre-menopause patient, two ways are both available. And after the menopause, from the ovary is stopped. So just the adrenal gland, this way is available. The tamoxifen is used to react with the estrogen. So it can stop this way, also this way. And the AI is just to stop the aromatase enzyme. So it can just function at the adrenal gland way. So this is why aromatase inhibitor is just used the post-menopause patient. Okay, last systemic therapy is targeted therapy. The targeted therapy we now find it's mainly used in the HER2 genes. And we have used the drug named trastuzumab. It was a humanized monoclonal antibody. And which kind of patient will have such kind of therapy we should use for the SERVA-B2? The patient with the immunohistologic examination, it will find the protein SERVA-B2. If the result is 3+, it means the gene, HER2 gene, is positive. Or we just directly to detect if the HER2 gene is positive, we can use FISH method and CISH method. And the FISH method is available now in the clinical work. And if in the FISH method the result is positive, we can give her such kind of antibody. But it's so expensive. We should use the antibody for 1 year. And 1 year totally, it will cost about 300,000 yuan. Of course, there's another targeted therapy drugs touched both the EGFR and HER2 genes. It's named lapatinib. It will just in the experienced stage, not used in clinical. We have some clinical trials use this lapatinib, but now it's not used popularly. Okay, all over the class.